All right, let's talk about one of the most incredible, most dramatic moments in any person's life, taking that very first breath. I mean, really think about that for a second. For 9 whole months, a baby's lungs are developing in a world that's completely filled with fluid. And then, bam, in a single moment, they have to perform one of the most complex switchovers in all of biology. So, how on earth does that actually work? Well, welcome to MedHub. We are so excited to be launching our brand new series where we're going to break down every single organ system you need to know for USMLE Step 1. And what better place to start than with the incredible story of the respiratory system and that very first breath. So here's our game plan. First, we're going to look at the blueprint for how lungs develop. Then we'll see what happens when that construction goes wrong. After that, we'll meet the microscopic workforce of cells that makes it all possible. And finally, we'll tie it all together with a really important clinical story about surfactant and neonatal respiratory distress syndrome. Okay, let's dive into Section 1, the blueprint. The way our lungs develop is this amazing feat of biological engineering. It all starts from just one tiny little bud and branches out into this huge, intricate tree that's designed to keep us alive. This image here gives you that perfect bird's eye view of the whole process. The big takeaway is that it all happens in 5 very distinct stages. It starts just a few weeks after conception and, believe it or not, continues for years after you're born. It's this incredible journey from simple tubes to complex air sacs. So let's break down what happens in each of those stages. All right, let's really dig into this table because it's packed with high-yield info. It all kicks off with the embryonic stage, where the basic scaffolding gets built. But look at this next one, the pseudoglandular stage. The key thing here is that up until week 17, breathing is completely impossible. The airways are just simple tubes, and there's nowhere for gas exchange to happen. The real game changer is the canalicular stage. This is when the all-important respiratory bronchioles start to form, and right around week 25, a fetus actually has a shot at surviving outside the womb. Then, the saccular and alveolar stages are all about creating millions and millions of mature alveoli, a process that actually goes on until you're about 8 years old. The big clinical point here is that a fetus's viability is totally tied to hitting these developmental milestones. But, you know, this is biology, and things don't always go according to the blueprint. So what happens when there's an error in the plans? That brings us to our next section, when construction goes wrong. Let's look at 3 classic high-yield examples. First up is pulmonary hypoplasia. This is when the lung is underdeveloped, often because something else is in the way, like a diaphragmatic hernia, and it just doesn't have the physical space to grow properly. Then you have bronchogenic cysts. Think of these as little leftover pockets of tissue that pinched off incorrectly during development. They can fill with fluid and cause all sorts of problems. And finally, choanal atresia, which is a straight-up blockage of the back of the nasal passage, something that can cause serious breathing issues for a newborn. And here's a pro tip for your exams. You absolutely need to know this connection. Choanal atresia is a key component of CHARGE syndrome. This is one of those classic clinical associations you'll want to lock in for sure. Okay, so we've looked at the big architectural plan. But who's actually doing the work on the ground floor? It's time to zoom way in and meet the microscopic workforce, the cells that make all of this possible. So this slide gives us a look at the cells inside the alveoli. The image on the left is a real micrograph of what they look like, which is pretty cool. But for our purposes, we're going to focus on the diagram on the right because it really breaks down their jobs. Let's talk about the 3 key players here. Type 1 pneumocytes, Type 2 pneumocytes, and the alveolar macrophages. This right here is such a key comparison. Your type 1 pneumocytes make up a whopping 97% of the surface area. They're super flat and thin, and they are designed for one thing and one thing only, lightning-fast gas exchange. But the type 2 pneumocytes, while they only cover about 3% of the surface, these guys are the real MVPs. They've 2 critical jobs. They act as stem cells so they can repair the lining after an injury, and they produce that absolutely essential substance we call surfactant. And of course, you can't have a functional system without a cleanup crew. That's where the alveolar macrophages, also known as dust cells, come in. These guys are constantly patrolling the alveoli, gobbling up dust, bacteria, anything that's not supposed to be there. They're basically the lungs, security guards, and sanitation department all rolled into one. And all of this, the development, the histology, the cell biology, it all leads us to our final section. This is where everything collides in a really high-stakes clinical scenario. Let's talk about the story of surfactant and neonatal respiratory distress syndrome. So, what exactly is an RDS? It's a direct result of not having enough of that magical stuff, surfactant, made by those type 2 pneumocytes. Think about the inside of a wet balloon. It's kind of sticky, right? Surfactant acts like a coating that breaks that surface tension, preventing the walls of the alveoli from sticking together. Without it, the air sacs collapse every single time the baby breathes out, which makes breathing incredibly difficult and exhausting. So, is there a way to predict this? You bet there is, and the answer is right here in this graph showing the lecithin to sphingomyelin ratio, or LS ratio. For most of the pregnancy, the levels of these two are pretty much equal, but I want you to focus on what happens right around week 35. See that massive spike in lecithin? That's the green light. That's the lung basically saying, okay, I'm ready to go. An LS ratio of 2 or more tells us the lungs are mature and the risk of NRDS is nice and low. So what puts a baby at risk? Well, the number one factor by far is prematurity, being born before that big lecithin surge. Maternal diabetes and C-section deliveries also bump up the risk. But the good news is we have a plan for this. We can give the mother steroids to help speed up the baby's lung maturation, and after birth, we can give the infant artificial surfactant directly into their lungs. And there you have it. We've gone all the way from a simple little bud to a complex, fully formed lung taking its very first breath. We've seen the architectural plan, we've met the cellular workforce, and we've understood a critical disease. But knowing how the lung is built, well, that's only half the story. Because once you know the structure, the next logical question is, how do we measure how well it's working? How do you actually test the function of a living, breathing lung in a real patient? Well, that is a perfect question, and it's exactly what we're going to break down in our next explainer.